I'm Dr. Jeffrey Lieberman of Columbia Psychiatry, here today for Medscape at the American Psychiatric Association meeting in San Francisco, which is celebrating its 175th anniversary. And with me is Dr. Christine Moutier, who is the medical director of the American Foundation for Suicide Prevention. Christine, great to have you here.
Thank you for having me.
Well, any effort to try and inform practitioners and the public about mental illness and mental health care has to have right up at the top of priorities a discussion about suicide, which you're in a position to know sort of the most and the latest developments with. Let me just ask you to talk to that, but also just to confess what may be, hopefully, a misimpression of mine, which is that, given the gravity of suicide, given its clear, manifest awareness of people of the fact that this occurs in our population, it seems to me that the Mark Twain adage applies. Everybody talks about the weather, but nobody does anything about it, because the suicide rate has not gone down over so many years despite medical progress.
That's true. I do think that there is new science, though, that's shedding light, even more so in terms of what drives suicide risk and what really constitutes effective suicide prevention efforts. And that is true also for the clinical world and clinical interventions that are still, to this day, being developed and being studied that specifically target suicide risk reduction. So it is so important that we translate that science once we know that there are effective treatments and system change that works into clinical practice and really scale it around the nation.
So what you're saying, and what I do believe and know, is that there's a clear knowledge base of how to identify individuals at risk and how to implement treatment or preventative measures, but it's not being applied adequately.
That's right, and I think that's because there have been some misunderstandings and because the science is really truly still evolving with new data showing us what is effective. I think in the past there has actually been a lot of confusion between prevention and prediction. So for example, in cardiologists don't bother with the problem that you can't predict who's going to die and when in their field, but they know specifically which risk factors to go after in order to reduce overall mortality and improve people's lives. And that's really what we need to be doing also in suicide prevention. And there really are changes in practice that aren't just about screening and assessment, but are about the care steps to take, whether you're a mental health provider or in primary care, or in an emergency department for that matter.
Can you just explain to clinicians that may be viewing this exactly what steps one would want to take in evaluating and then trying to put in place a prevention plan or surveillance plan, and also why aren't we doing it?
Sure. So once you've identified that a patient may be at risk for suicide, it's really important, of course, to do a more full suicide risk assessment if you have that time to do that. But if you're in an acute care setting or some situation where it's not possible to do the full suicide risk assessment, then there are still steps that you should take. If you have not heard about safety planning as a brief intervention, that's a very important, fairly recent development. That includes lethal means counseling and other steps that the patient actually can take to learn about their own triggers.
So let's just break it down. So you're a clinician, you have somebody that you're treating, either seeing for the first time or that you've seen before, but there's some reason that why you're concerned about their potential for self-harm. And first thing you want to do is assess, right?
Yep.
And then after that, there is a plan.
Yes.
Okay, so the assessment, what does that consist of?
Okay, so a suicide risk assessment really needs to go far beyond just the assessment of the suicidal ideation, plan, method, and intent. It includes all of the past history that constitutes risk factors, prior history of trauma, family history of suicide, early childhood adverse events, and then there's the current life circumstances, including changes in the person's life, of course, changes in their cognition around hopelessness and sort of how they're able to think through their current circumstances. If it seems like they are someone who normally thinks very flexibly and creatively in their coping, and now they are not, and it's narrowing down. That is a very concerning moment of cognitive constriction that happens with higher acute risk.
So it's not simply saying, have you thought of hurting yourself, and do you feel suicidal? There are these other risk factors that may not be directly associated with self-harm, but because of studies and statistical analyses are known to increase sort of risk of this possibility. So
that's right.
Are most clinicians aware of that?
I think if you're training in this day and age, that is more of the norm. But I believe if you trained more than 10 years ago, you didn't learn to practice this way.
So where can clinicians find that information?
Well, there are several training programs that are offered. My organization is launching one, starting actually with primary care, but it will soon be available to mental health clinicians
as well. Is this something you can get online, or do you have to actually attend some kind of conference?
It will be online, but if you go to afsp.org, you can learn more. And specifically, because of our chapter network in all 50 states, they are interested in giving this training to their local clinics. So that's something that you can also contact your local AFSP chapter for.
Okay, so the message is that if you don't know, like when I was training, unfortunately I didn't, I'm learning now, you can either go online or you can go to a local chapter to get the description of the assessment protocol. And then what about the prevention plans?
Right, the prevention part really involves several steps that are fairly basic, but things that I think due to clinician anxiety and other barriers that are there, we weren't all trained in, for example, safety planning as an actual brief intervention that you can do in the moment with a patient.
What does that mean?
Well, safety planning is a process that takes about 40 minutes to complete, and it teams up with the patient to help them identify their own warning signs and triggers for crisis and suicide risk. And then it outlines a series of steps they can take. And it's a plan that they actually keep with them. There's an app for it. This was developed by Greg Brown and Barbara Stanley. And it's a very useful and increasingly evidence-based risk-reducing tool.
So when patients have feelings or thoughts, that they can utilize this as a way of mitigating that or preventing. And what about their family members?
The family members should be involved, of course, if the patient gives permission. I think that many clinicians have become confused about HIPAA and have forgotten that they should ask the patient, and they may assume that this is information that the patient doesn't want shared. But the truth is, when it comes to safety planning and also lethal means counseling and making the home environment safe, the family and significant others, and even sometimes a close friend, are very important partners in that can help support the patient's plan.
What about after safety planning? Then what?
Well, after safety planning, you continue to care for the patient. And so that's one of the main things, is that if your patient is at risk of suicide, rather than feeling like, well, I can't get them into that specialty care, if you're in primary care and you're feeling like I don't have a solid referral that can see them, this week or in the next 2 weeks, it is really critical to know that a phone call or a visit, shortly after the current one, can be life-saving. And I know that sounds so simplified, but one of our strongest evidence base for the suicide preventive care that's really being recommended now, even by the Joint Commission, includes follow-up caring contact. In a review by Luxton, 9 out of 11 studies of things like postcards, text messaging, and phone calls, let alone in-person visits, showed risk reduction for subsequent suicide attempts.
So after your assessment and your safety plan, you maintain contact. But in the background, you're treating the underlying condition, right?
Of course, right. You're always targeting the primary psychiatric condition or conditions. And I think the new way to think about suicide prevention is that you're also thinking about suicide risk in its own category. So there are specific steps to take in addition that can include what we're talking about with regard to screening, risk assessment, safety planning, lethal means counseling, the follow-up care, but also evidence-based treatments that specifically target suicide risk, like cognitive behavioral therapy for suicidal individuals, like DBT, especially when there's borderline pathology, but even when it goes beyond that. DBT is found to be very effective for adolescents, for example, who've had a suicide attempt. And there are also things to keep in mind in terms of medications, with some new advances happening, and also with the underutilization of an old one, like lithium, that has a very strong evidence base for suicide risk reduction.
So do you need to adjust your approaches based on if it's psychosis, which is command hallucinations, versus somebody who's morbidly depressed and hopeless?
Certainly, if you as the clinician have identified a pathway that leads them to become suicidal over and over in their life, that would be important to go after that. But one way to look at this too is we're so accustomed to thinking from our clinical lens and our training with the DSM, and that's of course very solid, but when it comes to suicide risk, it's very multifactorial. New science is showing that there are genetic risks for suicide that fall outside the genetic risks for mental illness. So there are other factors at play, including cognitive traits like inflexibility, rigidity, impulsivity. So as a clinician, I would try to kind of take a big step back and look at the big picture and sort of beyond just the clinical diagnoses that we're used to operating in, and think about suicide risk as truly multifactorial.
But if they don't have an antecedent disorder, they're most likely not seeing a psychiatrist. They're most likely be seeing their primary care physician,
that
if
is
anybody.
true. That is very true. And that's why it is so important that primary care gets more involved in suicide preventive care.
Is zero suicide rates achievable?
When I say zero suicide, and when I say suicide is preventable, I actually don't ever mean that, just like with heart disease mortality, that every single case can be prevented. It's more about, we have science that tells us these are evidence-based measures and steps to take. We have not even scaled that yet. And so, of course, like every other leading cause of death that has a health basis, there is a prevention pathway from a public health standpoint. So that's the way I look at it in terms of the zero suicide framework.
So you're being cautious or not over-promising, but just like pulmonologists might say, if we eliminated smoking, we could have X fewer deaths from respiratory disease. But we can't necessarily say that yet with suicide prevention methods.
Well, what we have done is an analysis, and if you go to our website, afsp.org, and you look at Project 2025, we did an analysis of what would happen in terms of the number of lives saved if 4 pathways introduced the evidence-based interventions and were scaled up state by state with a rollout rate built in and everything, and determined that we actually could get to the 20% national rate reduction by 2025 if these 4 pathways
a 20% reduction,
scaled.
or down to 20% of the current level of suicide?
No, 20% reduction.
That's all?
It's suicide prevention turns out to be a hard task, and there are other forces at work, of course, like the economy for the population,
sure, life events,
and the opioid epidemic, and many other kind of societal factors.
That's right. Well, as you say, it's multifactorial. So even if 20%, that's a lot of people, a lot of lives. Why hasn't it been done?
Well, believe it or not, an analysis and an action-oriented sort of business plan for suicide prevention had never been done before. We have a national plan.
I'm asking you why.
I think that we haven't understood it well enough, and it is such a complex issue. I think a lot of the myths have been creating confusion. I think policymakers have been increasingly interested but unsure that there are steps to take.
Okay, so
that's going to change.
Oh, it is?
Oh, yes.
How is that going to happen?
Well, for example, in the last few years, policymakers are finally listening. So
policymakers meaning government officials?
At the federal and at the state level.
Gordon Smith, remember Gordon
Smith?
Yeah,
oh yes.
He's the president or head of the National Association of Broadcasters. And he obviously has a personal experience with suicide.
Yes, right, and the Garrett Lee Smith Act.
Right, right. So have you thought about approaching him to try and use media?
It's a great idea. And there is a recent study that shows that all of the states that got Garrett Lee Smith grant funding for suicide prevention for youth actually saw a reduction in the forecasting of what the youth suicide rates would have been in a sort of state-by-state analysis compared with the states that didn't have the GLS grant. So that's at the community level, really showing that when you train up an army of people who are interacting with youth first line, including parents, teachers, law enforcement, others, that you can save lives. Now, what we always do in those trainings is we drive at-risk individuals to the health system to get care. And so again, back to our original conversation, that is why it's so important that healthcare professionals are sensitized, trained, that they know what to do, and that health systems have learned and changed treating suicide like an actual health outcome to track, just like they do other health outcomes.
How much overlap is there between suicide and violence?
Very little in terms of harming others in the act of suicide.
Mm-hmm. I mean, you see a lot of individuals that are kind of murder-suicide scenarios. I gather that accounts for a very small percentage of overall suicides.
I think because that is so highlighted in the media, and appropriately, we don't want the media covering every average citizen's suicide. There are 130 of those happening every day. Mm-hmm. So it is a fraction, and my opinion is that there isn't enough data truly to do a really deep dive in terms of the science behind murder-suicide. But the little that we have in terms of those case reports is that it looks like there are key differences, and of course there are some similar driving factors as well in terms of mental health, disturbance and desperation. Mm-hmm. But in terms of, the vast majority of people who are suicidal are not even thinking of harming anybody else.
Mm-hmm. So the current state of the art is we have a body of evidence that allows for risk assessment, and then we have safety planning protocols that can be used, and all of this would go in the context of the overall treatment plan of an antecedent condition, if there is one. Is there anything that's either scientifically been studied or is on the horizon in terms of a diagnostic measure, meaning a genetic basis, a biomarker, a measure of serotonin neurotransmission viability, et cetera?
Some of the science is looking at all of that.
We never want to overpromise because then we lose our credibility. But and I'm familiar with a lot of what is being proposed. But you're in a position where you have a view, and you also have to exercise a degree of objectivity and restraint. But is there anything that you're really excited about right now?
In terms of biomarkers?
In terms of depression is associated with suicide, probably one of the highest associations of the condition, right?
Right.
But not everybody who's depressed is suicidal, right?
Mm-hmm. Right.
So what is it that makes them suicidal? So presumably there's some added factor, which is either related to depression or not.
Okay.
Is there anything that enables us to identify that?
Well, the difficulty is, the answer is yes, but it's not going to be simple. And so some of the cutting edge science is really looking at predictive analytics with big data, using AI and machine learning.
So that's your risk factors. You have a profile of somebody.
But it's not just historical risk factors and things in the EHR.
Yeah, no, it can be life events, what's happened.
Right. It could be how you're utilizing social media and changes in behavior patterns around that.
And we see contagions occurring. So these are transient events that are. So, but those are all maybe contributory, so multifactorial. Well, look, with schizophrenia, it's anticipated that there's probably 100 to 200 genes involved, with depression even more.
Right.
So why should suicide be, able to be pinned on one single biologic substrate?
That's right, and it will always be a different set among those multiple risk factors, and for any individual who is at risk, it's likely going to be multiple risk factors that are interacting and converging and causing that sense of acute suicide risk and desperation. It is important for clinicians to know and to be reminded, although I think we know this as we live it with our patients, that acute suicide risk is actually very temporal. It's a very short period of time. And suicide risk is dynamic as well. And so that's part of the reason that your ongoing care and contact with your patients alone, let alone if you do anything else in terms of referral into a specific evidence-based treatment like CBT or DBT or CAMS, is very likely a large contributor to them holding on to their reasons for living. That's an inventory that is one of my favorites to check out if clinicians haven't had a chance, is Reasons for Living, Reasons for Dying. It's a tool that can be used in clinical practice, and it comes out of some treatment models like CAMS.
Mm-hmm. So it's not high tech, but these methods are effective. Well, Christine, I could go on asking you things, and there's nothing that's more important than this. So thank you for coming and talking about this today, and keep up the great work.
Thank you, and thanks to all the clinicians who are tuning in and eager to learn more about suicide preventive care.
So the information is out there on what to do, and it's available to you. And if you can't find it anywhere else, it's available at the American Foundation of Suicide Prevention. So thank you for tuning in, listening. Hope it's been helpful. Dr. Jeffrey Lieberman, Columbia Psychiatry for Medscape.